Good afternoon, everyone. I'm Dr. Monica Malampalli, Executive Director of the Alliance of Sleep Apnea Partners. Welcome to the Breathing Room. It's an ongoing series to engage with public to discuss topics related to lived experience and importance of patient engagement and advocacy and innovation. This is a signature program of the Alliance of Sleep Apnea Partners. For those of you who don't know us, we are a nonprofit advocacy organization very much dedicated to being patient-led, patient-focused. Our mission is to promote and advocate for screening, diagnosis, treatment, and management for optimal health for those who suffer from sleep apnea. Today's episode is about physician perspectives regarding the Philips Respironics recall of the breathing devices. For some of you who joined us last week, we heard about patient perspectives regarding the recall. Philips Respironics recall is the largest recall to affect the sleep apnea community. And to this day, positive airway pressure or PAP therapy is considered the gold standard treatment for sleep apnea. So you can understand the significance of this recall to the patient community. So in this episode, we will speak with physicians about the impact of the recall on their practices and what efforts they and their professional societies have made to support patients with the recall. We will also hear from two researchers about some survey findings related to the recall. We will discuss what they have learned, challenges the physician community faced, and what changes they would like to see in the way sleep apnea healthcare is delivered in our country. We also want to hear from you. So if you have opinions and questions for our panelists, use the question and A button on your screen to type your question or a comment. All right, let me introduce you to the panelists. Dr. Mohammed Adil Rishi, please come on. You can join us now. He is a pulmonary critical care and sleep medicine physician. He's the chair of the Public Safety Committee of the American Academy of Sleep Medicine and an associate professor of medicine at the Indiana University School of Medicine. Dr. Vaishnavi Kundel has been an assistant professor of medicine in the Division of Pulmonary Critical Care and Sleep Medicine at the Icahn School of Medicine at Mount Sinai in New York City since 2019. She's actively involved in the American Thoracic Society's Sleep and Respiratory Neurobiology Assembly, as well as the American Academy of Sleep Medicine. Dr. Rebecca Robbins is assistant professor in medicine at Harvard School of Medical School and an associate scientist at Brigham and Women's Hospital. In 2011, she co-authored a book on techniques for how to get good sleep entitled Sleep for Success with Dr. James B. Mass. In September of this year, Dr. Robbins published a paper titled Quantifying the Impact of Philips Recall on Patients with Sleep Apnea and Clinicians. And she'll talk a bit more about some of the research that she's done. Dr. Tetiana Kinderska is an associate professor in the Department of Medicine, Division of Respirology at the University of Ottawa, with a cross appointment at School of Epidemiology and Public Health. She has been documenting patient and physician experiences following Philips Respironics recall in Canada. Most recently, ASAP has partnered with Dr. Kinderska and her colleague, Dr. Sachin Pendarkar at the University of Calgary to capture patient experiences within the United States. All right, welcome everyone. And let's get started. So like I mentioned, last week we spoke with patient advocates, and today I have you here to understand the perspectives from, your position as physicians and researchers. As you all know, Philips Respironics recall for the breathing devices started in 2021, June, and we're still dealing with some of the aftermaths. So in your opinion, from physicians' perspective, what did you see as the biggest problem in all of this, since you've been following this recall from the beginning? Dr. Rishi, you want to go first?
Sure. So I guess where to start? So it's not too distant memory that, it was a pandemic going on, and then you get a big recall hit sleep medicine community. I kind of laugh with some of my colleagues that it seemed like it was the second pandemic in the pandemic. That's what it felt like, at least to the providers who work with me and to our patients. The size of the recall, I think, was a huge problem. And the fact that it was so hard to ramp up production because of everything that was going on with the pandemic itself, made responding to to this recall so much harder. And the results are in front of us. I think the second big issue that I would point out was the communication. And I think we've kind of suffered through this last 2 years, partly because, the communication was not good from Philips, but I think Philips is not the only one to blame. I think the way FDA handles these types of recalls, now that we've gone through this once, I think it's easy to see that that's not optimal, and something has to change there as well if we are to improve this type of situation. If it ever happens again, which I hope it doesn't.
Yeah, I hope the same. And thank you for pointing that out, because this is something that came up in our last webinar too. Communication gap was one of the biggest issues. Dr. Kundel, you want to comment on this?
Yeah, I mean, I echo everything Dr. Rishi mentioned. It did actually feel like we're coming to maybe hopefully a close on the COVID pandemic, and then this kind of hit in the summer. I remember it was right after this sleep meeting that they announced this.
Yep.
In June. And so, yeah, it did feel kind of like a little, mini pandemic of it on its own. I echo what Dr. Rishi said. The communication was really difficult. Just like, making sure patients get the right information, and then figuring out if they know if they even have an affected device, right? Because there was so many devices floating around. And then also like instructions to then register your device for replacement. That wasn't always easy, especially often in the elderly population. So that was very difficult to communicate. And I think the most frustrating thing on my end was really, really getting the supply chain shortages, right? Like, so getting them a new device. We often had patients that were, maybe diagnosed 6 months ago. They just got that device, and now they're technically not eligible for a new device for 5 years from their insurance. And they have to wait, a couple of years to get a replacement device. So that was one of the most frustrating things, because it makes you feel helpless as a physician, because you want to really help your patients, but you kind of, not sure where to go. So I think those things really stood out.
Thank you for that. And just for our, patients listening in, SLEEP is a conference, annual conference every year where a lot of researchers and physicians get together, and as well as the industry folks. So there was no announcement made at the SLEEP meeting, but it was done right after. So it took everyone by surprise. You also briefly touched upon supply shortage. I think supply shortage of CPAPs, but one thing that a lot of people don't know, there was also a shortage of some of the components. But for now, let's not get into that. But there were other issues that were happening right around that time that made it more complicated. Dr. Kinderska, what are your thoughts?
Yeah, I absolutely agree with everyone. What I want to add actually is one critical point. It was even really difficult to find patients, because we don't have registry of patients on positive airway pressure therapy. We don't document manufacturer of those positive airway pressure therapy devices. And so this is like why we need that registry. So we cannot find patients. We cannot warn those patients. We tried our best. We just placed on a website that letter with the Philips Respironics recall notes. But the second issue was very limited. Even I would say it's lack of information at the beginning of the recall. It was very difficult to have those conversations with our patients, and very difficult to make informal decision. Should we continue with the therapy, or should we stop the therapy?
Thank you. Dr. Robbins.
Not much more to add. The excellent points from my colleagues. And I'm at my core kind of I study health decision making in patients and how to make decisions and understand situations like this. And it was a really unique patient decision making context without the lack of clarity that my colleagues touched on. Many providers themselves were forced to kind of do this challenging kind of trade-off and discussion with patients of like, this is an uncertainty. There may be carcinogens and it may be cancer causing, but it's also a life-saving treatment. And how are patients supposed to make sense of that? So I think it was really challenging on a lot of fronts for all parties involved.
I think it's interesting because your perspective, you're watching this from the outside, looking at physicians, you're looking at patients and noticing, what's happening with the communications. One of the things we also learned from our patient panel last week was lack of trust. Like, now patients are finding it very difficult to trust with what all that has transpired so far. So communication is trust. Let's move on to the next question. So how, again, this is more for the physicians, but then Dr. Robbins, you can also weigh in. How did the recall impact your patients and sort of their treatments? What were we hearing from them? And what was their primary concern when they were reaching out to you? First of all, I think I have to acknowledge a lot of patients didn't even know this was happening. But then if they found out, what was it that you were hearing from them? Let's start with Dr. Rishi.
Yeah, sure. So I think the biggest issue was that patients, when Philips initially put out this recall, they actually told patients to stop using their devices. That was the initial communication that went out. And that was a huge problem. Some of the patients showed up like 3, 4, 5 months after the recall was issued, and they had not been using devices. Some of them probably should not have stopped using their devices. And it is a decision that should be very customized to the patient's needs. And that initial instruction from Philips was not appropriate. Subsequently, Philips changed their language after the FDA put out their own advisory about the recall, and their language, subsequently mirrored FDA's language. But I think that was a big problem in the beginning. The other issue, obviously, was that patients who came back to see their providers did not have trust in the PAP devices, in Philips devices or some other manufacturer's devices, because they were worried about what could or may happen, in the future. And as I think about clinical decision making, when you see a patient, every treatment has risks. There's almost no treatment that I'm aware of that has no risk, like 0% risk. There's no such thing. When you're making these types of decisions, you are weighing the risk burden against the potential benefit. The problem for the longest time with this recall has been that we don't know the risk burden. As a clinician, it's very hard to recommend for or against an intervention when you don't know that piece of information. And that information, at least to me, is still not available. Most recently, Philips has come out with reports from the independent laboratories that have been working with them, stating that there's no perceivable risk. But FDA right afterwards came out with their own again update stating that they don't necessarily agree, and now Philips has agreed again with FDA to do more testing. So kind of going back to that lack of trust, it's very hard to trust if the recommendation keeps on changing like that, or the information that's coming out keeps on changing. And as clinicians, again, if you don't have that information, you don't really know what to tell your patients, and that's the hardest part.
So the couple things, what you said. One, somehow people got the Philips messaging first before hearing from their physician that to stop using the machine. So that caused a lot of confusion, right? And second, you're saying the messaging sort of changed because as a physician, you would have advised your patients before we gather more information, let's keep to your treatment, because we've heard from patients who've said they had stopped their treatment and their condition has worsened. So thank you for that. That was important. I just wanted to capture that. Dr. Kundel, what do you want to add to this? What have you heard from your patients?
Yeah, I mean, I think one thing to add with what Dr. Rishi mentioned was, uh, like, so there was really no kind of not a lot of information that Philips provided, and some of the symptomatology that they mentioned was vague, and it's very non-specific, headaches, congestion, which often a lot of my patients have congestion or headaches, and so it's really hard to kind of pinpoint it to say it's your CPAP. There was no guidance, scientific guidance, like how long should you be using the CPAP to kind of, experience these symptoms, right? So I think that there was a lot of, kind of vague, like really no science backing on some of these kind of symptoms. And like, it was kind of hard, puts the physician in a hard place because we don't really have the answers. We just have the information that was provided by the FDA and then Philips. And then the other thing I would say, your question was, how did the recall impact your patients? I feel like I had kind of a lot of patients in two buckets. One was, there was a lot of mistrust. And so they essentially were absolutely against using the recalled unit which I totally understand. It was very much a shared decision-making process with each patient, very individualized process. And then there was another bucket of patients that had been on CPAP for 10 years or, 5 years or 2 years. And, they said, hey, doc, look, I can't live without my CPAP. I haven't noticed any of these symptoms. And we reviewed everything, and then they made the decision to continue using the unit because they felt the benefit was more pronounced than the risk. So I felt like it was a lot of those, either one of those two buckets, and each decision that we made was individual for each patient. So it was a lot of shared decision making.
Thank you for that. Yeah. Again, I mean, just hearing this. So let me again understand just clearly. Did ATS or ASM at that point have any opportunity to talk to Philips directly? Did you reach out? Did your organizations reach out to Philips and have that conversation saying, what do we tell our patients? Because looks like you all were taken by surprise as well. Was that any of that communication that happened directly to you or to ASM or ATS from Philips?
So I'm representing ASM, so I can comment on what happened at the ASM in those early days. So I'm not aware of any direct communication with Philips. FDA did reach out to various physician associations, including ATS and ASM and CHEST and others, regarding how the practices of physicians and patients were impacted, and we did provide feedback in that regard. We also conducted webinars, kind of like this one, within a couple of weeks, in fact, of the recall. Actually, 2 such webinars were done, looking at the impact of the recall and looking at special populations who may be impacted by the recall on the second webinar. And ultimately, within, I think, a month to 6 weeks of the recall, based on physician consensus, there was a logarithm that was put out by the academy of what might be best practice, not evidence-based, but because there is no evidence or was no evidence at the time, but what may be the best practice in terms of how you address, as a physician, patients who are coming in with these recall devices. And so we did the best we could under some very trying circumstances.
Dr. Kandel, do you want to add anything from what ATS did?
Yeah, I mean, I think this addresses one of your questions later, but ATS did put out a editorial statement in August 2021, which kind of, and then I know that there was another statement by all the sister societies, CHEST, ASM, and ATS. But ATS did put out a statement in August 2021, kind of to inform the efforts and identify key steps forward. And kind of like Dr. Rishi mentioned, A lot of it was, to kind of to help physicians figure out how to move forward, which patients should continue the device. Patients with, lots of comorbid diseases, lung diseases, respiratory failure. And then, beyond that, I think that was already out, but beyond that, they also recommended patients that are driving for, for long periods, they should probably continue to use their CPAP because of the risk of accidents with daytime sleepiness. Patients that have severe sleep apnea with a lot of, low oxygen levels. And so they put out kind of additional expanded list of things that we should really consider to continue treatment because the risk of not treating outweighs the benefit of, and then also I want to say that you mentioned our institution or our sleep program actually had a meeting with the Philips Respironics representative, I think July or August. They came on for like a meeting with the faculty to we were trying to understand when the patients would receive the units, the recall, like a replacement unit. And that's we didn't really get much more guidance than what was already out there in terms of what to do with these patients, but we did find out then that it would be, they were very honest that it would be, 6 months to a year at least before these replacement devices would go out. So, and that was with our institution.
And you were able to convey that to your patients, that it was going to take that long?
Yeah, so after that meeting, that's essentially what we had to convey that to our patients. And it was, like I said, it was a process where you feel really helpless at times, but yeah.
All right. Let's move on because
sorry, Monica, I just want to add that as a part of the Canadian Thoracic Society, so we did the same. We also have a statement and we have some sort of as a guidelines based mostly on expert opinion, and we reach out Philips Respironics to have those discussions. And also just to add to our previous discussion in terms of my patients' interactions, I have a certain group of patients who were asking when I can get that device. And this question was very difficult to address. And one more point I believe we haven't covered, it's actually because in Ontario, we have a bit different sleep medicine system. We have in-lab therapeutic sleep study, and our in-lab therapeutic sleep study were affected because of affected Philips Respironics devices for titrations. Yeah, thank you.
Oh, okay. So that's interesting to hear that, that's something, again, we haven't touched upon at the hospital systems and other places, the impact of, not having these devices available. Let's come back to Dr. Robbins, because I think you have some data that you want to share. Let me pull up your slides. And this is, again, in keeping with my question that I was asking about, what did you hear about the physicians and patient concerns? Let me bring that.
Thank you. And this really just kind of puts some numbers behind some of the excellent points that my colleagues have made. This was a study that we did. We finished data collection in July of 2022 and published shortly thereafter. So this reflects that year following the announcement. So if you could go to the next slide, please. And what we did is we used the American Academy of Sleep Medicine directory to contact sleep specialists and providers and ask for their participation in a survey. Next slide, if you can
see. Hold on. This is.
I have the PowerPoint, if that would be easier.
If you can open that up, that might be easier. Yeah. Let me then stop sharing and I will give you. Yeah, you can share.
So this was published in the Journal of Clinical Sleep Medicine.
You want to put it in a projection?
Terrific group of colleagues. And the background we've already discussed so far, but the goal of this project was to start to quantify some of the impacts and get a sense at the time where we were with the recall. I saw the question in the chat about kind of where are we now, but this kind of gives a snapshot again of that 1 year post recall. So our objective was to deliver the survey to a sample, a convenient sample of members of our American Academy of Sleep Medicine directory comprised of specialists and patient advocates. So we did 3 methods of recruitment: direct mailing through the ASM membership, email blasts, and also post to the member-only discussion board. Members were screened for their eligibility. They did need to be seeing patients. Currently, the breakdown of participants was primarily physicians, followed by nurse practitioners, physician assistants, sleep technologists. We had 1 dentist, and so on and so forth. Relatively equal balance in gender. And here's some other demographics that are also in the full paper. This is just some data to back up what folks have been saying so far. And this was a question: where did clinicians and patients, clinicians are shown in gray, in black, and then clinicians were also asked to report where they understood their patients received information about the recall. So some interesting differences here. Patients, according to their providers, most commonly heard about the recall through news. So I think that sheds a little bit of light on opportunities to maybe, should there be another instance of this, to better communicate to patients and providers, instead of having this kind of what we call in the health communication world a 2-step flow of information, not directly from a provider or from the manufacturer, but instead through a news outlet where the information, the messages might not be as accurate as one would hope. Clinicians primarily heard about the recall through Philips Respironics, but still only 25% reported hearing about the recall through the manufacturer. Specifically, 23% reported through their clinic, and still 14% of providers reported first hearing about the recall through the news, which is kind of a remarkable statistic. And then social media, a form of communication for patients, is reported by their providers. Again, these are provider-reported treatment approaches. So providers reported most commonly advising their patients, although echoing Dr. Kundel's point, and wonderful reports of the shared decision-making model, that was the most common decision-making approach that providers reported taking with their patients to help them make sense of the recall and just make a decision. But then kind of within that, 62.4% reported advising their patients to continue using the device. 9% reported advising their patients to stop using their device. But that's kind of shown in stark contrast to what providers estimated their patients were actually doing. About a similar proportion, according to providers, of patients reported continuing using their device, so 60%, but then 26% were estimated to stop using the device. And again, for a life-saving treatment, some interesting and compelling kind of questions about ethics and decision-making. And then use of alternative therapy. This slide displays some of the reports from providers about the impacts of the recall, not only on patients, but also on providers. Red indicates minimal disruption, minimal to significant disruption. So in other words, a disruption. Blue indicates neutral or not a disruption. Some of the most compelling here that were touched on, and just to put numbers behind some of the excellent points made by my colleagues, my patient's health and well-being was the most severely impacted, followed by the provider's reported stress, and then work-life balance, health and well-being. Many of our providers anecdotally provided some comments in the survey indicating, this was extremely onerous for providers to respond to. It created an excess burden, having to have one-on-one conversations, just a huge influx of communication from my patients. And then this is particularly concerning: my patients' trust in medicine. 83.3%, reported a minimal to significant disruption in a patient's trust in medicine. And one of the things I was thinking about, as one of my colleagues was talking, is the parallels to the COVID-19 pandemic. I think that this kind of shed a light on some of the desires from patients and the public generally to have a level of certainty from the healthcare community and scientific community. And when there's flip-flopping, as Dr. Rishi touched on, now we're recommending this, but before it was this, I think that's really hard for patients to understand. And then you add in the fact that sleep apnea is already an extremely complicated condition, and patients are already reluctant and demonstrate low rates of adherence. It's complicated. They have to maintain a certain level of usage. They have to engage in trial and error. And so to add this on top of all of those challenges to sleep apnea, really just further raised concerns and barriers that patients face to successful treatment.
Thank you for that data. That was definitely pretty powerful. Just going back to one of the slides that you had, where the healthcare providers were suggesting stopping the device and then again using alternate therapy. Were you able to dig deeper and see who were suggesting that? Were they physicians or there were nurse practitioners, or were you able to kind of quantify some of that? With who was suggesting that kind of I mean, clearly majority were saying stay with your device and continue the treatment.
Sorry, my is going crazy over, man. We did not do any sub-analyses about which type of provider was recommending which type of therapy. That would be a really interesting follow-up question. I think the sample was a little bit too small. We did only have 65 physicians providing feedback, but that would be an interesting question if we're able to get a bigger sample.
Because I think that can also allow us to do some targeted communications as well. Because FDA was saying the same thing, that don't stop your treatment, but also if you're able to use alternate therapy or speak to your physician. So again, not really saying who needed that, the alternate therapy. And I think there's just more conversation that's needed there. Again, thank you, Dr. Robbins, for that. That was very, very helpful. Dr. Kinderska, do you want to share your slides? You had some information too that you wanted to share with us, the study that you did.
Perfect. Yeah. Can you see my slides?
Yes.
Okay. Okay, so, and I just want to overview our study, which is still in progress. And
can you put your mic closer? I'm sorry.
Okay. Yeah, can you hear me?
Yes, that's
okay.
That's
so it's still in progress. And actually, when we started this study, because we relatively recently got this HR grant, we saw that we are late. And unfortunately, we're not. So all devices still not replaced in Canada, and from my understanding, in the US as well. And so in this study, we want to characterize and quantify adverse health effect associated with the use of PAP devices affected by the recall. So we want to bring more certainty in terms of cancer, respiratory, atopic, kidney, liver conditions, importantly in terms of anxiety and depression. And we want to explore how the PAP device recall has impacted patients, healthcare providers on different levels, and also sleep medicine health services in Canada. And finally, we want to use all this information and also collaborate with our colleagues in the US and in Europe, if possible, to develop those strategies to mitigate the impact of current and future positive airway pressure devices recalls. And we're going to use multiple sources of information using interviews, surveys, and existing databases. And on this slide, you can see that we have done a data collection in terms of interviews. We interviewed 47 individuals, and we try to have representative from different stakeholders, including patients, respiratory therapists, sleep physicians, primary care providers, and policymakers. And during my next few slides, I'm just going to show you some quotes from different stakeholders. And on these slides, you can see a quote from a respiratory therapist. And we're missing respiratory therapists in our conversation. And actually for them, it was very difficult to be that middleman with no information and with all this request from patient when I'm going to get that new device, and also trying to navigate in that confusing information, how to register this device. And in Canada, actually, you're supposed to register the device in 2 places, and with your respiratory therapist and with the Philips Respironics, which is very confusing. And we are not able in Canada to get those devices directly, only through the respiratory therapist. So this is a sleep physician perspective. And I know that we had a lot of, we already pointed out a lot of critical points. What I want to tell that not only those people on Philips Respironics were affected, but also our patients with untreated sleep apnea and recently diagnosed sleep apnea were affected as well. because as we were talking, we are at the end of the pandemic, in the middle of the pandemic, with the Philips Respironics recall, with the electronic shortage, and we have this waiting list to get your new device for patients with very severe sleep apnea, with all this occupational risk, with very severe comorbidities, and I cannot prescribe this treatment because devices are not available. And this is about our patients, and you had this separate webinar. I just want to point out why we included actually anxiety and depression. Anxiety and depression were not listed as potential side effects associated with the devices. But this is what we see in our patients. We can see this anxiety and fear associated with using the device and having this decision-making process, if I should continue using the device, if I should stop using this device. And this is in terms of survey, and if you have any patients for others on call who are interested in participating in this survey, just reach me and I will be happy to share this information. And this is where we started collaborating with Monica. So up to date, those ones, the most recent numbers, we have 107 responses from Canada, and we have 74 responses from the US. And in terms of existing databases, this is an example of manuscript we published already using a secondary data analysis while looking on association between positive airway pressure therapy devices manufacturer and incident cancer. And we published this manuscript in Blue Journal in 2021. And it's based on about 7,000 individuals with a median follow-up time of 7.5 years. And on that time, we haven't found any association between Philips Respironics devices and incident cancer. But this study has a lot of limitations, and we were not able to look on separate cancer subtypes. And also, we looked only on cancer. We haven't looked on other health consequences, and this is what we are going to do in this project. Thank you.
Thank you, Dr. Kindes. So So just to again emphasize, you did not find any association between.
We did not find any association between Philips Respironics devices and incident cancer with all subtypes of cancers combined.
Okay, and you looked at other manufacturers as well in that data and came to the same conclusions. Just
correct. Yeah, we compared Philips Respironics with other manufacturers, and the second large manufacturer in Canada is ResMed device. Yes.
Okay, great. Thank you for that. Again, quantifying some of this information is great because we need that information. We need that data. And again, I did notice the initial numbers that you had were small, but hopefully, through your survey, we can get the word out and have more people respond to those questions. So we're very happy to partner with you on that. And I will put in the link to the survey, or it's on our website as well. So, this is again to the audience, please let, your network know that there is this survey, and we're very interested in capturing that information. There is a question. I guess one question has been answered, I guess. Let's come
Monica,
back.
I did chime in to say, at least at the time of our publication, I responded to the question,
Okay.
but this was just 1 year after the recall. Our data showed, according to providers, that they reported 35% of patients were still 1 year post-recall waiting for devices. But I would be really curious, I also said in my response, to hear from my physician colleagues on the line about where we are now. I would also be really curious.
Yeah, absolutely. I'll open that up. Do you want to weigh in? So the question was, where are we today with respect to health problems related to the recall and any steps to address them?
Yeah, so I can comment on that. So I primarily work at a county hospital in downtown Indianapolis, and I think location is important, as we've seen through this recall. Not every place had recall devices at the same time. Larger cities, those DMEs which were high volume DMEs tend to get devices earlier, and then the smaller towns, center of the country, and smaller DMEs, had to wait longer. So I can tell you that, at the place where I'm at, it's a county hospital. Most of my patients are poor, are minority communities, indigent, a lot of patients who are uninsured or underinsured, undocumented. So that's the patient population that I deal with. And I think, 30% is probably an underestimate of how many of my patients who had Philips Respironics devices are still on the recall devices. I think maybe 50% who had the recall devices still have recall devices. And I think, that's where this gap in the healthcare system in general, I think, is at play. These are the people who always get left behind. And guess what happened? The same thing happened this time around as well. The same patients get left behind. I think we have to be honest about how our healthcare system works. Patients who had the means are not on recall devices. They were not on recall devices within a couple of months of having the recall. They just went out there and bought the machine, like $1,000 machine. They just went and bought it. So 2-3 years out, the only patients who have the recall machines are those who don't have the means or did not have the ability to get on the internet and get their devices registered. So our old and the elderly and those who don't speak English and those who don't have access to internet, or those who are in jails, those who can't advocate for themselves. Those are the patients who are without devices right now. And unfortunately, when you work in a county hospital, those are the patients that you serve. Those are the patients you're trying to advocate for. I think that's the truth. I think, and I'd like to hear from my colleagues where the situation is, where they're practicing. But this is where things are in downtown Indianapolis.
Thank you so much for pointing that out, because we don't think about some of those patients who are really in need of these, these machines. And you're right. That's what we've heard. A lot of patients who had the means were able to go buy new devices and were able to continue with their treatment. I want to open that up. Is there anyone else who wants to comment on that? Dr. Kundal, Dr. Kenderska?
Yeah, I practice in New York City. So, we have a pretty large sleep program. Even so, I would say at 1 year, I would say majority of my patients still did not have their, replacement unit. And then like a lot of times, so at 1 year, certainly I would say majority didn't have it. I completely agree with Dr. Rishi's point. The patients that had the means either went out and bought a CPAP, or they have the time to advocate for themselves and really push and work. And so anecdotally, now there's no data on this, but I ended up seeing the patients that have more means ended up with a replacement unit sooner than those patients somehow, whether they bought it, whether they pestered the DME or whatever it was, then the patients that marginalized from marginalized communities. And then I feel like a lot of the other patients also, they ended up getting the ResMed units. I feel like later on, a lot of my patients got their refurbished Philips unit. So I certainly see that disparity because I think when you have the means, you have the time to advocate for yourself. And so that was definitely evident where I work as well.
I do want to point out to this comment by Randy Boston. He said, yes, that corresponds to my experience. I administer a Facebook recall group and partner with 2 other groups with about 13,000 patients total. I don't know the percentage, but a lot of them still don't have replacement devices. So it's still continuing to this day. And I think we have to recognize that there are patients who are still waiting to receive their devices. And it'll be interesting to know what is still the problem with some of these folks who have not, are still waiting on their devices, whether it's a backlog with Philips or they also just don't have the means, to, get it replaced or whatever the reason is. And I think I think that'll be good to know. Dr. Kinderska, do you want to add anything to that discussion before I move?
Yeah, so far, yeah, I agree with everything said by my colleagues. And in Canada, we also have probably about 30% of people still not without devices being replaced, and also Philips Respironics started replacing different parts of the device, not really the device by itself. And it depends from region and from the population. So I absolutely agree with Dr. Ricci. And we are lucky in Canada because for our patients on disability, we have 100% coverage for those devices to be replaced, but it's only once in 5 years, which means if you just got the device, I cannot do anything about it. So this is why I think, yes, we need to focus on this marginalized population and find the way to help them.
We've also heard that, there are people who had sort of brand new machines and then the insurance would not cover for a
Yes,
device. So that was another issue that some
the
of the
same.
run into.
And I also want to point out again, because of that miscommunication and absolute lack of information on who is affected, it is still possible that we don't know about those patients who are using recalled devices, and given that those devices were recalled and they were manufactured in the last decade. So it's still possible that those patients on very old devices, 10 years old devices, never heard about recall because they have no access to internet, they cannot speak English. So, and we don't know how to reach those patients even to help them.
No, so true. All right, so let me ask this again. This questions from the physicians. There have been some deaths that have been reported, by the FDA. What type of long-term effects are you expecting to see in your patients, like the ones who have been impacted by the recall? And is there something ATS, ASM, even Dr. Kenderska in Canada, are you thinking about anything on those lines? Of how do you monitor these patients, if they come back or who have been impacted, and or some of them have continued to use these devices like we've spoken, and versus also people who have stopped their treatment. So is there any conversation that is happening at ATS, at ASM, or even in Canada in monitoring some of these patients for long-term effects?
I can start with our study. So in Canada, again, just because we are in Ontario and we have coverage for sleep medicine, we have this information available in health administrative databases, which means that we can follow those patients through health administrative data. This is how we did in our study on incident cancer. And I mentioned those outcomes that we want to look at. So we want to look at those respiratory conditions, on asthma and COPD exacerbations, on hospitalizations, emergency department visits, and including all-cause mortality. But this is a point that we need to bring probably to FDA and to the Ministry of Health in Canada, that we need that registry of patients so we can contact those patients when we have these future recalls, and we can follow those patients in terms of risks and health outcomes. Because even with self-reported data, with health administrative data, it's still possible we have this like misclassification bias. We're still missing something. And so it's still better than nothing, but we need that registry.
I'm asking this also because, our last week in our discussions, the patients touched upon examples that, similar breathing issues have happened before, whether it's, with the 9/11, first responders, whether it's, the asbestos thing. So I think the physicians in the breathing sort of the field have experienced or have, come across some of these types of issues. So again, keeping that in mind, again, I want to come back to Dr. Rishi, Dr. Kundal. Has ATS or ASM have thought about next steps or any type of guidelines, anything for the future to say, okay, how do we monitor these patients, who have been using these recall devices?
So yeah, I think, in terms of, if you look at what we know right now, there are two main types of side effects which can be potential problems down the road. One is airway reactivity or COPD or asthma-like symptoms related to the actual particulate matter that gets into the respiratory circuit of these devices. There is actually, I think, some data that's already published I think it was published in the European Respiratory Journal last year, demonstrating increased need of bronchodilators in patients with COPD. So that's one issue that we kind of know about, and so certainly I think it's it's recommended that physicians who are caring for these patients, down the road, continue to monitor their patients for these types of symptoms. The other one is the more difficult nut to crack, which is the genotoxicity. So not only does the foam breakdown result in this particulate matter getting into the circuit, but also fumes, which you can't see or smell. And these fumes have been not only associated with, theoretical increased risk of cancer, but also the testing results that have been put out by Philips. Several of those tests also demonstrated, levels that can be genotoxic. Although Philips eventually came to the conclusion that there's no long-term risk. If you look at the reports in detail, I have to admit it's hard because very detailed, and it's very kind of medical language heavy. But basically what that means is that this risk of at least the theoretical risk of cancer. And that's a harder nut to crack, because when you have gene mutations, the genotoxicity, that doesn't present like a month from exposure or a year from exposure. Sometimes it can be several years or even decades. In terms of what you were talking about asbestos, the latency between when you have asbestos exposure and when you develop cancer related to asbestos like mesothelioma, it can be several decades between the two. And so that's much harder to monitor for. And I think the hope is that the governing bodies, for example, FDA, the government, and Philips, will come together and monitor these patients who have been on these devices, in a longitudinal fashion, to see if those types of problems develop down the road. I think that's the only way we will know, whether or not this is a problem, and that data is not currently available.
Well, thank you for that, because that's what I was going to suggest. If ASM, ATS, and CHEST are able to even pull together an interdisciplinary type of group of various specialists, but pulmonologists, toxicologists, even oncologists, cancer specialists, sleep specialists, and then come up with some type of recommendations or something, that we are able to convey to the patients as well as the physicians, and say that this is something we need to watch out for, because we're still so in the midst of the recall, still focused on what is happening. But I think it's time to start thinking about next steps, what to expect sort of in the future. So, and again, I invite ASM, ATS to work with ASAP. We are here as a patient advocacy group, and in however way we can facilitate those conversations, we would be very happy to do that. Dr. Kundal, I want to give you the opportunity to answer too, but let's come back, because there are couple questions here that I want to get to. One, how do the clinicians feel about prescribing second-tier CPAPs that may have been more readily available during the recall? You're right. So far, we've talking about Philips, and then we've heard about ResMed, the two very common, well-known companies. But how about companies such as React Health, Transcend, ResVent, Air Mini, etc.? Trust in technology versus availability, etc. So anyone wants to answer that? Dr. Kundal, you want to take that on?
Yeah, I mean, so for us, I think the main units that were used, I think, and it's true for most places in our institution, were either ResMed or Philips. Those are kind of the dominant in the market. Mm-hmm. Honestly, I will say the the type of device that the patient gets is actually, at least the way we function, it's not up to the physician. It's what the DME has in stock. And so usually we don't specify the type of device. Sometimes I do when the patient requests, you know, they specifically don't want a Philips ever again, which I've had many patients say that to me. But it's usually, especially because how this recall affected the supply chain. So it was really whatever the DMEs had that was then distributed to the patients. So yeah, I mean, the DMEs normally don't have like an Air Mini. Usually they have the Luna, which is, you know, been used more frequently now. So a lot of my patients have the Luna. I usually have no problem with, you know, those devices. But again, it's really what is in stock with the DME that dictates what type of unit the patient will get. So often my patient would get a refurbished Philips, and it was like the older unit, and they didn't want it. And unfortunately, like it's very hard to control that piece.
So I guess what I'm hearing is perhaps there's also a little more education that's needed here to let people know that there is innovation, there are other devices out there, there are other treatments available too. So let the patient then understand the options that they have, right? And not feel like there isn't much.
Yeah. Sorry, I just want to add that I did end up referring patients a lot more to you know, our obesity clinics and obesity counseling that often you know, takes a longer time, and then also dental sleep apnea devices. You know, those referrals went up just because there was such a backlog with the CPAP.
I have one more question. Would any of you recommend specific testing, for example, like that used to screen long-term smokers?
I mean, I think there's no data for it. So to have a screening program like that, you need to demonstrate that screening will actually, you know, one, catch cancer early, and two, will be cost effective in terms of disease management at a societal level. And and that is what has been shown for lung cancer in smokers, and that's why we have a lung cancer screening program for smokers at a specific age, up to a specific age. And you know, so until you have that data, you know, you just can't implement a lung cancer screening program for this patient population, especially because we don't know if exposure to these devices actually causes lung cancer. So I think unless that data is available, that's not something that I'm recommending.
All right. Well, thanks for answering that. And just to kind of, again, point out, Dr. Rishi, Dr. Kundal, ASM and ATS have been in contact with the FDA. You've been having conversations with them, right? So again, both the professional societies are doing their best to get the information out. Just want to point that out. Is that right? Okay.
Yeah.
Okay. All right. So I'm looking at the time. We're almost out of time. Thank you. This has been great conversation. I still encourage our attendees to send us questions, because again, I can then forward them to you. We can continue sort of those conversations still. But just a quick response to a couple other questions. From a physician's perspective, what changes would you like to see happen to protect patients from a future recall? Like, again, Dr. Kindeska said, we may not be able to prevent the recall, but what steps can we take to mitigate the impact of a recall? So do you want to answer? Just give me quick answers to that.
I think the whole process needs to be revamped. I think that's all I can say. I think it's, you know, it's a difficult question. Probably one sentence is not sufficient to answer this question. But I think if I was going to put it in one sentence, I would say the whole process, from the FDA to the manufacturers, to the communication, to the development of the device, everything needs to be revamped.
All right, ASAP will be very happy to continue conversations with you, Dr. Rishi, on that. Dr. Kundal.
Yeah, I mean, I think I have a similar. We need system level changes. It's not the patient, it's not the DME, it's not the provider. It's the way our system works, and that's very difficult, and it will require a lot of intricate kind of, you know, I think discussions. So I think it's in line with Dr. Rishi said.
Oh, thank you, Dr. Robbins.
Could not agree more. The system level approach, and just, of course, in a perfect world, this is not, something that we'll have to face again, but it's just so challenging to overcome from the standpoint of the patient perspective, because I think it's a very nuanced conversation. But from the most simplistic standpoint, some patients, CPAP already has a bad rap in certain circles as the mask, and unfortunately now it's the mask that caused cancer in some very simplistic views. And so understanding how all of this is translated to the patient perspective kind of just shines a light on how important, avoiding this is in the future. But couldn't agree more education around CPAP, around how important it is and the treatment for sleep apnea. Yes.
So system level changes take a lot of time. So maybe Dr. Kenderska, you can, instead of answering that question, maybe you can just say one message that we would like our audience to take away. Let's keep it something positive.
Yeah, because I also wanted to say about system development, system change. I think that we need to start with devices development as a first step, actually. So just to be more rigorous and just to avoid situation like that in the future, that can help this to prevent future recalls, also to have great registration system. And importantly, we need to invest more in those novel treatment for obstructive sleep apnea. We have mentioned multiple times that obstructive sleep apnea is a heterogeneous condition. We have this all obstructive sleep apnea phenotypes, and we need to invest more so we have alternative options for other patients next time, more options.
Well, thank you so much for that. Let me just wrap up now because we are out of time. I want to thank all of you today for the engaging conversation. I also want to thank our funders, ASM Foundation, for supporting this series and making this program possible. For our audience, if you have any stories that you want to share about the recall, please email us at info@apneapartners.org. You can also write to us if you have any questions related to the recall, any other issues that you're having, and we might be able to help and also connect you to our panelists. Please sign up for our newsletter if you have not done so yet, and stay connected with ASAP. Again, Bree, I just want to say that this is an ongoing virtual series. We'll come back to this topic again in January. We're talking to other stakeholders as well. Please look out for our announcements, whether it's through our newsletter, as well as through our social media, Facebook, LinkedIn, Twitter, X, and Instagram, and YouTube. This video will be available on YouTube as early as tomorrow or day after. And again, thank you all for joining us today, and see you all again soon. Wish you all a wonderful holiday season and Happy New Year. Thank you.
Thank you so much. Have a good one.
Bye-bye.
Thank you. Bye.